Welcome again, everybody. This is a liver case on a 47-year-old female patient. This case is dedicated for juniors since lots of students and junior radiology residents asked about this in relation to our previous case. So for juniors, there you go. Let's concentrate on the liver. You're looking at the patient from her feet. This is anterior, posterior, right, and left. This is the liver. You probably noticed you have this large hypodensity, which is a bit heterogeneous, has different colors within the dome of the right liver. And lower down within the liver, you've probably noticed another lesion as well. This is more homogeneous and well-defined. The first staging point is a repeat of what we said before, change to a contrasty window. So let's do this together. I'll change from this window, which is the soft tissue window, to what we call a hepatic window. This window has a width of 400 and a level of 40. We're going to change that to 150 and 100. And let's make the switch here. You could see how the lesion is much more obvious. Let's do that again for the other lesion and switch to the liver window, and now it's even more obvious than before. So you basically have two hypodensities within the right hepatic lobe, one heterogeneous, one homogeneous. This is what you see on the pre-contrast image. We agreed for assessing hepatic lesions you need to have arterial, portovenous, and delayed acquisitions. So this is a phase here where you have contrast that's extremely dense within the aorta and no contrast within the IVC or the portal vein consistent with an arterial phase. So on the arterial phase, we're going to look at the hepatic window to make things more obvious. And now you see that large, well-defined hypodense lesion showing peripheral nodular-like enhancement. Looking at the other lesion, you might wonder about tiny nodular peripheral enhancement as well. Now, this pattern of enhancement is classic for hemangioma. Basically, hemangioma is a non-neoplastic, very common finding of the liver. The easiest way to remember it is as a bag of blood. The most diagnostic finding for hemangioma is that this bag of blood fills slowly from the periphery inwards. It mainly fills by hepatic arterial supply, and the classic descriptor of such supply is peripheral interrupted nodular. Some books will describe that as peripheral puddling. It's important to remember that no matter how the hemangioma enhances, the enhancement should be equivalent to the blood pool, meaning that the density of the enhancing part should be equal to the density of the aorta. Now this bag of blood or hemangioma fills slowly from the periphery, so if you give it more time, you're going to see more enhancement going into the center. And that's what we'll try to observe when we go to the portovenous phase. Now you have a less dense aorta and more enhancement of the venous structures. This is portovenous. And here's that large hepatic lesion showing more confluent peripheral nodular or interrupted enhancement. Of course, this would be more obvious if we change the window, and that's the enhancement here. You have more enhancement in these areas as well. And if we go to the other lesion, the smaller one, you start to see more enhancement at the edges here. And here's a more delayed image after giving contrast. This is 3 minutes after injecting contrast. You could tell that this is very delayed since you have washout of contrast from the vascular structures and contrast within the renal collecting system. And you see more progressive filling of the abnormality by contrast from the periphery inwards. More obvious when you change to the hepatic window, and notice how that the blood is equivalent to that of the blood pool. If we go to the other smaller lesion, you have more progressive filling from the edge. That's where we stop the examination since it looks very characteristic, but there's a good chance that this would fill more if you give it 5 to 10 minutes delay. And finally, to complete the story, this is the ultrasound on the same patient concentrating on the right hepatic lobe, showing you a very characteristic appearance of hemangioma, very homogeneous, very hyperechoic and bright with a well-defined border. In summary, hemangiomas are very common. On ultrasound, they're characteristically hyperechoic and well-defined. On CT, they're hypodense and well-defined on the pre-contrast phase, and they progressively fill with the peripheral nodular interrupted enhancement pattern on subsequent phases. Always remember, with hemangiomas, the enhancement density should be equivalent to that of the blood pool of the same phase. Now, this is something that you'll see very commonly when you do abdominal imaging. This is a good revision for juniors. That's it for typical hemangiomas. However, atypical hemangiomas become more interesting. Hopefully in the near future I'll show more atypical hemangiomas for which a discussion would be more interesting for seniors. That's it for today's case. Thanks for watching, and we'll see you with more cases later. Hi again. This is an MRI of the brain on a female adult patient. This is a good case to contrast with the case that we saw a while ago of a left cerebellopontine angle lesion. Now, most of the points here are directed for seniors, but as usual, I tried to simplify this for juniors. We're looking at an axial T1 MRI of the brain. T1, the CSF is dark. This is the brain above the tentorium. This is the brain in the posterior fossa. Here's the left and the right cerebellar hemispheres, and this is the brainstem. And the brainstem is compressed by this abnormal mass. So this is a mass in the right cerebellopontine angle. You have to decide if the lesion is intraaxial arising from the brain or extraaxial arising from outside of the brain. To differentiate both, we talked about that in previous clips, but quickly looking at this, you know that this is compressing the brain from outside. The bulk of the lesion is centered outside, and it has a well-defined CSF cleft separating it from the brain parenchyma. This part that you see here is the temporal bone, and bone is not as clearly seen on MR as you see it on a CT scan. And from within, the bone is covered by dura mater, that part of the meninges that's more adherent to bone. And since this lesion is widely based on the temporal bone, this is what we call a dural-based abnormality. So those are all features that are consistent with an extraaxial right cerebellopontine angle lesion. Now let's characterize this lesion further. The intensity, the color of the lesion, is similar to that of gray matter, so it's isointense to gray matter. Looking at a T2 image where CSF is bright, the abnormality appears heterogeneously hyperintense, and as you see, it displaces this vessel here. This vessel here is the basilar artery, compared the same color to that of the carotid arteries on each side. And although we agreed that this lesion is extraaxial, it compresses the brain and you have secondary reactive edema within the brain here. This is the same abnormality after administration of intravenous contrast, and the lesion intensely enhances. Now, the major differential diagnosis here would be that of a meningioma, schwannoma, and depending on the patient's age and history, you might add metastasis or lymphoma. On the prior clip, we talked about a few differentiating points between schwannomas and meningiomas. What favors a meningioma here is the wide dural base. And if you look here, this is where you expect the internal auditory canal to be. There is no extension into the canal. Most schwannomas would have extension into the canal, so these two features would go with a meningioma. If you have an enhancing dural extension, which we call a dural tail, that would favor a meningioma. We don't see a dural tail here. Another feature that you could look for is the presence of calcification. We know that calcification, especially if small, could be missed on MRI. CT would better assess that. Many meningiomas adjacent to bone are associated with bone changes, which we call hyperostosis, which is also a feature that is difficult to see on MRI because bone and calcium is better seen on CT. Let me jump quickly to the non-contrast CT and then we'll come back again to the MRI examination. So this is the CT scan without contrast. You see the lesion again. Let's concentrate on the bone here. And if you look at the bone on bone window, you'll notice that you have these irregular extensions off the cortex of the temporal bone, consistent with hyperostosis, which is another feature that favors a meningioma here. Now back to the MRI examination. This is the T1 with intravenous contrast. Everything tells us that this is a meningioma of the right cerebellopontine angle, but the story is more complicated than that. For seniors, have you noticed this? This is the internal auditory canal, and you should see no enhancement at all there. Any enhancement is abnormal. We know that the 7th and 8th cranial nerves pass within the canal and they're surrounded by CSF. Whenever you see an enhancement there, it raises a possibility of a neoplastic process, in particular a schwannoma. And most commonly schwannoma of the 8th nerve, a vestibular schwannoma, although other less common neoplastic and inflammatory conditions may give you some enhancement. And for all those keen eyes out there, have you noticed this as well? This is another enhancing extraaxial lesion. Here's an additional lesion as well. And multiple similar extraaxial lesions along the falx, as well as one in the brain convexity here. Now, with the exception of this lesion here, which we called a schwannoma, all the other lesions are consistent with meningiomas. Since you have multiple meningiomas and a left vestibular schwannoma, you have to raise the possibility of neurofibromatosis. In particular, neurofibromatosis type 2 is classically associated with meningiomas, schwannomas, and ependymomas. So this was a case of neurofibromatosis type 2. Hopefully in the future we'll talk more about the differences between type 1 and type 2. Now let's summarize what we talked about today. First, we emphasized the importance to decide if what you're looking at is an intraaxial or an extraaxial lesion. Second, the main differential diagnosis for a right cerebellopontine angle lesion would be schwannoma versus meningioma. You could include others as well. Third, the internal auditory canal should be looked at very carefully. Any abnormal enhancement may mean a schwannoma. Fourth, for calcific changes, whether in the bone or within a lesion, CT is much better than an MRI. Fifth, calcifications, hyperostosis, lack of extension within the canal, dural tail, and a wide dural base would favor a meningioma. A sixth important teaching point is when you see one lesion, look for the others. Don't get distracted. Finally, the presence of multiple meningiomas, schwannomas, and ependymomas is consistent with neurofibromatosis type 2. And that's it for today's case. Thanks a lot for watching, and let's see you with more cases later.